Melly, can we start recording? Great. Good morning, everyone, and welcome to our weekly Monty Hardcast conference. Um, I wanted to say a special hello to all the residents who are interviewing today for our cardiology fellowship. We hope your interview day will go well, and thank you for joining Monty Hard. It'll hopefully give you a flavor of everything Monty has to offer as far as a program. So today we're really lucky to have a very good friend. We worked together many years ago, Sandeep. I don't remember how long ago. It was 10 years ago
No,
when we
no,
were in
it was
Milano.
2011 to 12.
Oh, wow. Some time ago. So after we worked together, Sandeep's gone on to become very well known and internationally recognized in the field of coronary intervention. He's leading a lot of clinical trials with drug-coated balloons, and he's a very thoughtful operator, especially when it comes to CTOs. So I really, I'd seen a lot of his cases, and I continue to learn every time he shows cases. So I thought it would be useful for him to share his CTO experience with us. So Sandeep, thank you again for joining us.
Thank you so much, Azim. It's a great pleasure. And as Azim said, I know him from almost 12 years now, and he's very inspirational. And I owe whatever I've achieved to him and for Antonio
Mm.
Colombo. So, yeah, thank you so much for supporting me all through. And we continue to collaborate. And of course, we are jointly going to be doing this research with DCB Magic Touch. So, yeah, I'm looking forward to working with you again. So, I made this talk on retrograde CTO-PCI recently, which was very well received. So I thought I will give you some talk on retrograde CTO-PCI. But before that, in terms of the experience from the fellows and everyone, I guess you have a very good CTO program. I was told you have a very excellent operator. So I'm just going to show you some of my cases and experience on retrograde CTO angioplasty. So I work in Birmingham in Heartlands in United Kingdom. So the retrograde CTO PCI will just go through a bit of definition and then when and why to go retrograde and tips and tricks and any complications we encounter during retrograde CTO PCI. So retrograde PCI is when you actively access the collateral channels to open a CTO. So as you all know, CTO is a complex anatomical subset. Um, in almost 30 to 40% of cases, you may have to go retrograde because antegrade, you're not making any progress, you're in a subintimal space, or sometimes even you can't even get into the plaque because it's heavily calcified. So the collateral channels from the donor artery will give an access for you to enter the body of the CTO from the back end of the occlusion. So retrograde CTO PCI is like when you actively access these collateral channels to open a CTO. Now, when we do CTO angioplasty these days, there's nothing called pure antegrade or pure retrograde case because as a CTO, as a complete CTO operator, you have to get to a stage where you have to switch from antegrade to retrograde uh, in the same setting because you're not making any progress antegradely. If you say, okay, I don't do retrograde, I'll stop here and I'll ask someone else to do it, then yes, you could still be called a CTO operator, but to be a complete CTO operator, you have to be able to do both in the same setting. So which means you have to be dynamic in your decision making and the procedural progress. So complete procedure operators have to be dynamic in their approach and ready to switch to retrograde in the same setting. So I consent my patients for both. So, I tell them, look, I'll try from the front end of the occlusion. If it's not working, I'll go from the back end. So I consent them so that they're aware and I'll tell them that they could be on the table for up to 3 to 4 hours. So when to consider retrograde CTO-PCI? So scenario one, if you're unable to catch the true lumen antegradely. So for example, if you see here, this is a RCA CTO in a post-bypass patient, and you could see there are collaterals from the septals from the left system, and here my wire has gone in the architecture of the RCA, but I'm not able to catch the true lumen. You see here, it keeps going subintimal. So at this point, you run out of options antegradally. Okay, you try parallel wire, whatever, but you could see this artery is quite diffusely diseased. So even if you want to use ADR, you may fail. But again, this is not an ADR case because your occlusion is right at the crux. So you don't want to lose both the branches. And of course, you have excellent collaterals. You use the channels to enter retrogradely. This is just one of the publications which basically shows that how things have evolved in terms of the JCTO score. So as you know, the JCTO score is an anatomical score which tells you the complexity of the CTO. If you have a JCTO score 0 or 1, they're simple CTOs. But as you go to 3, 4, 5, they're complex CTOs. And this yellow bar represents the retrograde. You see, if it is 0 or 1, you hardly need retrograde. So it's 3 or 9%. But as you go down the score, which is more complex cases, your retrograde number becomes high and high. Because if you look at JCTOS 5, almost half of the cases are done through retrograde. And your other things like anti-virus escalation gets smaller and smaller as the JCTO score gets complex. So JCTO score is basically the length of the lesion, calcification, failed previous attempt, and of course the calcification and angulations. So higher the score, complex the CTOs are. Um, so this is a second scenario where you want to go retrograde. So ioto-osteal lesion. So for example, here there is an occlusion of the RCA, and the occlusion is going right to the ostium. So there is hardly any lead into the occlusion from the front end because it's ioto-osteal occlusion. In these cases, it's very difficult to penetrate the cap from the front end because you got no support, no, sometimes even you don't even know where it is. Maybe you can see here because of calcification. In these cases, you have to start retrograde as your primary approach. So this is a case we did in our center in 2019. So this is again a post-bypass CTO. The RCA was not grafted here by the surgeon, and we were not sure. Obviously, you could see there's a flush occlusion. There's probably a branch here, which is a conus, but there's hardly anything you see. And you got excellent retrograde collaterals from the left system. Now, the CTO crossing algorithm, it's very important that you have to do a dual injection, and then you make a decision based on how the CTO looks. If you got an ambiguous cap, you got a poor distal target, if you got a good interventional collaterals, which means retrograde collaterals, and you've got any major side branch of the distal cap, you're trying to go more retrograde first. So in the next sections, I'm going to be discussing more of a technical aspects of retrograde CTO-PCI. Setup is very important. Now, I don't know in US, but we are very obsessed with radial, although I'm not totally obsessed. I go more radial and femoral. So I do one axis radial, the other is femoral. But in some patients, I go biradial. Very rarely I go bi.
Sandeep, I'm struggling to hear you. We lost your audio. Sandeep? Sandeep? Oh God, I don't think he can even hear us. I think let me call him. Can you hear us, Sandeep?
He's muted.
Yeah. I still can't hear you. It looks like you're muted again. I don't know if something changed on your microphone settings if you click on the side of the microphone and the speaker.
Can you hear me now?
Yeah, we can hear you now.
Perfect. Sorry for that. I didn't realize. So where did I lose you?
Now, at the beginning of the slide, you're on about access. We heard you talking about that you use one radial and one femoral.
Let's go there. Yeah.
So literally at that stage. So maybe talk about from why you use 7 French guides for your radial and femoral, and from there onwards. How about that?
Yeah. Can you see now? Can you see the presentation?
No, it just disappeared. It was there and now it disappeared.
Hold on. I'm still sharing.
Maybe I don't see a shared screen.
Okay, hold on. I think I'll share the screen again.
Yeah.
Can you see the screen now?
We can.
Okay. Can you see now?
Yes, perfect.
Perfect. Sorry for that.
All right. No problem.
So setup is important. So we tend to go more radial and femoral in our setup. So one radial, one femoral. So right radial and right femoral. But in some centers in some cases we use biradial, but very rarely we go bifemoral because obviously you have to put 2 7 French sheets, and we don't want to be compromising the access and complications. I tend to use 7 French guide on both sides. I know in US they use 8 French mainly, but here we use 7 French because that should be enough. But I never use 6 French guiding catheters for retrograde access because we will struggle a lot. Now, in terms of the length of the guide, as you know, the normal length is 100 centimeter, but we tend to use a short guide when you're doing retrograde. They say you have to use at least one guide to be 90 centimeter, but I prefer both to be 90 centimeters so that you have enough slack when the wire comes out, especially if you're accessing some of the epicardial collaterals, which is very tortuous and they're very long. If you take a normal length guide, you will not be able to externalize properly. So you have to take a short guide. Prefer to take both short guide because you have enough slack. Always take a supporting guiding catheters for both antegrade and retrograde, especially for the right coronary artery. Never take JR4. Go for AL1 or AL.75 because you need that guiding support, especially if you're spinning the corsair or if you're trying to grab stuff, you need that access and support. So this is just a setup I'm showing. So I've taken an AL1 guide and I've got a retrograde guiding catheter from the left for RCA CTO. So you see here, I trying to go antigrade now, so I fail. So I've taken a septal collaterals and I've taken a microcatheter, which has now come into the RCA, and this is kind of almost success. If you come to this stage, you should never fail because you just have to do a reverse cut and finish the procedure. Now, collateral consideration, there are 3 kinds of collaterals. You have a bypass collateral, which is obviously the most easiest one because you have a open vein graft, very nice access into the RCA, obviously here, which is a CTO, which you should always use it if you have it. Then you have septal collaterals, which obviously are from the LAD. And these are the most safest collaterals because even if there is a trauma or a damage to the collaterals, they are squeezed by the contracting muscle in the septum. So very rarely this needs any intervention. They normally close on its own. But epicardial collaterals are the one which generally comes from the circumflex system into the right. And as the name, they are connected to the epicardium or they're on top of the epicardium, which means if you do bleed, you'll bleed straight into the pericardium, which is why epicardial collaterals are considered sort of a high risk retrograde approach. And it has to be done only after you gain enough experience in retrograde. And this is just the table showing the different characteristics of the 3 collaterals. So if you look at the tortuosity, okay, bypass graft has got the less tortuous because it's easy to get in. Septal, the next level, but epicardials are very, very tortuous. Okay, again, difficulty with wiring.
epicardials are very tricky, and you have to be doing with very cautious mode. Ischemia during crossing, more with epicardial. Tamponade risk, as I said, epicardial have got the highest risk. Now, this is very important. Sometimes when you have a collateral, especially the septal collateral, if the microcatheter is not going, you can take a 1 millimeter balloon and just inflate to facilitate the passing of microcatheter, but you can never do that with epicardial. It's almost like a no-go zone. Never balloon epicardial. If it's not going, maybe you have to respect the anatomy and say we don't need to try this. So there are cases where I fail epicardial. Rather than taking more risk, I stop, because at the end of the day, as we all know, do no harm is probably the first motto of any angioplasty. So septal collaterals, this is important which wire you take. So I normally take a Sion and a Sion Black as a first choice, and then I reserve the more complex Fielder XTR and CO03 as my last choice, because in UK we have to be very conscious about the costing, because of course we are not a, a very rich nation compared to America, so we have to be careful. So we tend to start with something which is much more cheaper than CO03, which is quite expensive. So I'll just show you an example here. So this is a septal collateral. Okay, so obviously you enter with the microcatheter. So you can see there's a microcatheter here. You enter with a normal workhorse wire, which is could be Sion or a run through, whatever. And after that, you take a Sion Black. You could see here the wire is going and it's gone into the body of the RCA. And you see here, I come here, that's the microcatheter. The wire is in the PLV branch. And this is another case where there is a very nice septal collateral connection. So you could see here, I'm doing it's called septal surfing. So this is your microcatheter. This is just a Sion wire. You see here, it just goes in. Okay, so you just have to keep trying, not very aggressively, but just moving a little bit, and you can just feel, and with the heartbeat, it kind of goes. And this isn't a step which I always teach my fellows. This is sort of underutilized, because you see this collateral is like we call the heel of the septal. So it's like a very bendy. Now, a lot of the time where it's very difficult to spin the microcatheter because it offers a lot of resistance. So this is a very nice technique called balloon anchor technique. So you put a balloon in the diagonal, you inflate it, and you ask the second operator to tug on the balloon. So they're just gently pulling the balloon so that the guide is nicely anchored in the left main. And you could see here when you do that with some rotational movement, you see how nicely this traverses into the PDA. And again, you keep that look. It's just you keep watching now how this nicely goes in front of the into the PDA after doing the anchor. Epicardial collateral, as I said, this is a very nice depiction of how they are. They're extremely tortuous, okay? And the go-to wire now, it's almost default across the world, is something called a Asahi's CO03 wire. This is one of the softest wire you could come across. Tip gram is 0.3, and it's very soft. It's got a hydrophilic coating. It's very rarely damages the collaterals, but the problem is they lose the wire memory. So because it's so soft, it'll get damaged after a while. So which means you may have to sometimes take two wires, and these wires are expensive. So in a country like us, obviously we have to be extremely careful when do we choose this, and this is only dedicated CTO retrograde operator who can use this. So I'll just show you a case. So not playing on this. Oh, for some reason, this is not playing. Yeah. So this is a epicardial collateral from the LAD into the RCA. And you could see here, I've taken a microcatheter and I've taken few turns, which is a CO03 wire. But the most important trick is after 2 or 3 turns, it will stop moving because the torque sets into those loops, which means you will not be able to transmit the torque. So for that, you have to advance the microcatheter to release those loops and then make the next step. And the other trick with the epicardial collateral is not to push the wire, put a gentle forward traction on the wire, and it will do the job with the heartbeat. Unfortunately, this is not playing. I have to show you. I don't know why it's not playing. Maybe this will play. Okay, so this is a epicardial collateral from the right coronary into the LAD. You see how tortuous this epicardial collateral is. One thing I would like to say is, don't jump into an epicardial as a first choice if there are other options available like antegrade or a septal collaterals. But if you got no other choice, you have to at some point take this epicardial collateral. So it's not like a no-go zone, but try and be more pragmatic and take it only if there are no options available. So in this case, I tried antegrade, I failed. You see here, I've got parallel wire here, which means I failed to catch the distal true lumen. So I made enough attempt antegradely. Then I decided to go retrograde because I was not making any progress. In some centers across Europe, these collaterals are not taken by even by some of the CT operators. They'll stop and they'll bring the patient back or give it to someone else. But in our center, we carry on and do it. So for example, it's very tortuous. I put a safety wire in the RCA. This is important. You have to put a safety wire in the RCA so that if something does happen to these collaterals, you can at least balloon tamponade till you deliver the coils to stop the bleeding. So put a safety wire and take the microcatheter. So this is just a normal wire. This is not a CO03 wire. Now I change to CO03 wire. You could see it takes a loop, but you have to release that loop by pushing the microcatheter. See here, I'm releasing the loop by pushing the microcatheter, but the microcatheter should never go close to the tip. It should stay well before the tip, but you have to release the loop. And then look at the next step. So the next step is I'm release the loop, then I'm putting a gentle traction on the wire and it goes forward. Then again, you have to release the loop by advancing the microcatheter very gently to ensure it doesn't go beyond the tip. You see, I stop here. Okay, and then again, I make a next attempt to traverse the collaterals. You could see I'm just putting a gentle traction, releasing the loop. You see, I'm releasing the loop and I'm pushing the microcatheter and then making the advancement of the wire. You see now. Okay, now it's gone into the distal LAD. And then I got in here and I can finish the procedure. Never anchor when traversing epicardial collaterals. Like you saw, I showed a case where I was anchor the diagonal to spin the microcatheter in the septal, but that should never be done with epicardial. You should never anchor and then push because you will damage the epicardial collateral. Microcatheters, I always take 150, never take 135 because 150 is dedicated for retrograde. Septal collaterals, I take Corsair Pro as my first choice, Turnpike LP and Mamba, which is obviously the Boston Scientific, but these two, the Corsair is the Asahi one. Epicardial collaterals, I always start with the Caravelle first because it's a soft microcatheter. You don't need to spin. But I also have taken Corsair Pro, especially if it's a calcified CTO there, you need more meat on your microcatheter, then you have to take Corsair. This is very important. Once you arrive at the distal cap, what's the next thing you need to do? So there are three options available, okay? Either you do a retrograde wire escalation, which means you take a more stiffer wire like Gaia 3 or whatever, and escalate the wire to catch the true lumen proximally. But if the retrograde wire escalation fails, then you go for the reverse cart, okay? Now, sometimes you may have to do a knuckling. So this is a slightly different approach from European and the Japanese approach than the American approach, which is more of a hybrid where they knuckle the wire as soon as they're at the distal cap, irrespective of how the lesions are. In our center, we don't knuckle unless it's heavily calcified, where I'm not making any progress, where then we do this technique called Carlino, where we deliberately inject a contrast into the cap to induce a dissection, then we knuckle it. I'll show you some cases. So retrograde wire escalation is, some of these things are not playing. It's okay, I'll show this. So I think this case I will probably be able to show. Yeah, so maybe this shows. So this is a LAD CTO, okay? So you could see this is a sort of flush occlusion of the ostium of the LAD, and there's a nice RCA collaterals. Okay, so I tried antegradely. I always go antegrade first. I checked from the other side. I was subintimal. I tried parallel wire. Unfortunately, I could not catch the true lumen. So at this point, I stopped and I went retrograde. So this is epicardial collateral. So I got to my microcatheter here, and that's your CO wire, and which goes into the LAD. Now, at this point, as I said, when you come to this part of the procedure, you have two options. Either you could knuckle or you could go subintimal to do a reverse card. But what I did was here, I did something called antegrade wire escalation. I took a Gayatri wire, kept the microcatheter here. You could see the movement in the microcatheter. This happens very often in the epicardial collaterals where there's a lot of movement in the microcatheter, but don't be scared of it. It's okay. It's completely normal. And then I spun the wire and I got here, and you could see here my microcatheter here, and my wire goes into the antegrade guide. So here I've not used antegrade wiring at all. I've just done a retrograde wire escalation where the wire has gone from the distal end of the occlusion into the guiding catheter. When this happens in the LAD, you have to ensure that you did not come out into the left main through a subintimal space. So you have to do an IVUS. So I did an IVUS on the proximal LAD, ostial LAD, distal left main, and left main. You could see the wire in the circumflex. So this is the wire in the circumflex. Okay, so it's there, which means I'm in the true lumen. So you could see this is ostial LAD. There's a circumflex wire. So I am in the true lumen. So obviously we finished the procedure with the stent. Reverse cart is a controlled antegrade and reverse tracking. So essentially, you have antegrade wire in the subintimal space. You got a retrograde wire in the subintimal space. You connect the two by ballooning. So you balloon it, okay, and then you connect the two space. So here you see they ballooned it on an antegrade wire, okay, and then you take the wire, and this wire will now enter the antegrade guide. So we just say trial and error, and obviously it went into the aorta. So essentially what you do is by ballooning, you're connecting two spaces, and then you bring the retrograde wire into the antegrade guiding catheter, and then you do externalizing with the RG3 wire. So sometimes, for example, in this case, we had to use a guide liner. So it's a guide liner to catch the wire. So this wire is gone into the guide liner. So guide liner is basically extension of your catheter to catch the wire. From otherwise you'll have to bring the wire into the guiding catheter. Sometimes can be tricky. Sorry, if some of my slides were working yesterday and suddenly they stopped working. Maybe it's in this computer. Yeah, so this is basically a depiction. So this is my retrograde wire with the microcatheter. I've got an antegrade wire. So you see here they're dancing in a same plane. So the distance between the two is so small. So if you do a knuckling, which is what the hybrid operator does, that you create a bigger space between the two. So then you need a bigger balloon like 2.5 or 3 millimeter connect. With this, you don't need that much of a balloon. In fact, here we just used a 2 millimeter balloon. Okay. Yeah, see here, there's a balloon here. We just use a 2 to 2.5 millimeter balloon. We got the guide liner in. So you bring the guide liner down, and then you balloon it, and then you see now the wire going into the guide liner. So once this is done, the process is almost finished, where you just have to externalize, do an IVUS, and stent and balloon. Once your retrograde wire is in the antegrade guide, okay, you need to anchor the retrograde wire with the balloon in the antegrade wire so that you could milk or suck the microcatheter. You then exchange to RG3 wire and complete the procedure. So this is what's happening here. So you could see there's a balloon here which is inflated in the antegrade guide. The wire is already gone. So you inflate the balloon, you basically you are trapping the wire very hard, and then your microcatheter goes nicely into the guiding catheter. So this is another case you see here. So what has happened here, I'll show you, is so my wire has gone into the antegrade guiding catheter, and I've placed a balloon here. I've inflated a balloon, and then you see I'm milking the Corsair microcatheter into the antegrade guiding. Once that's done, you exchange it. And this is just a video to show. Can you see the video? No, it's.
It's
It's
stuttering.
jerky.
It's like stuck at the same picture.
I don't know. It's not playing. Anyway,
Anyway.
if epicardial collaterals, okay, I do a new technique called tip-in. Okay, this is something, I mean, not new, but it's relatively new compared to any other CTO techniques. It's basically when you have an epicardial collateral, you externalize the wire. So you basically got the whole heart in your hand. There's always a risk of avulsion of the epicardial collaterals because they are very delicate and soft and tortuous. So to avoid that degree of strain on the epicardial collaterals, we do a technique called tip-in. So essentially, you get your microcatheter into the antegrade guide, you leave the microcatheter here, and then you take just a normal wire like a fielder FC, and then try and go into the microcatheter. It's called rendezvous technique or a tip-in, where you push the wire into the microcatheter. If this happens, then you can bring back your entire retrograde system and just work on the antegrade wire. So I'll show you this case. So this is just a case you saw earlier where I got my microcatheter in the antegrade guide. So I parked it here. This is here, there. Okay. Then I bring in fielder FC wire. We'll watch now in a minute. Okay. So the fielder FC wire comes now. And I think, why is it there? Yeah, so you'll watch now the fielder FCA wire comes here. This wire comes there. Wire comes here. It's a bit of trial and error, but in the end, look, it catches here. It goes there. It's following that. So watch again. So
is there a place you recommend leaving the retrograde microcatheter to facilitate a tip-in? Like, or you just put anyway.
You could do anywhere, but I find it outer edge of the guiding catheter is where your wire comes in.
Okay.
So I tend to do it here, but sometimes I've done it in the lesion itself when things are not going well. But you could do it here. Some people do it in the arch, but for me the arch is very difficult to see because it's quite difficult. Some people even recommend putting a balloon to kind of squash the catheter, but most of the time it works. I've done around 5-6 cases now. It works. So it's here, watch it comes, the wire comes. You have to do a trial and error.
Yeah.
It'll just go in. And once this goes in, you'll see what happens now. I can just milk the catheter back. So this is the microcatheter. I just milk it back and I just work on the antegrade wire. So I don't have to worry about the retrograde collaterals anymore.
Right. That's great.
Complications, collateral perforation, and donor guide dissections are the two important things you need to be aware of. This is a slide which, again, it's one of the published article in the Euro Intervention, which basically shows that the perforation is higher with retrograde. There's no brainer. Okay, and of course, higher the retrograde, your overall MACE is high. So retrograde CTO-PCI is a complex thing, and it has to be done by a dedicated CTO operator. And even when you start off doing retrograde CTO-PCI, take on some simple cases, septal collaterals, and then slowly go towards the epicardial. Yes, your aim is to get to become a complete CTO operator where you can do everything, but you have to do it in stages. So this is a case I'm showing you. It's a septal perforation. Okay, so you could see there's a septal perforation, which is benign. And the reason I say that is because this patient had the procedure done and I failed to open it. So I brought him back. And when I rechecked it, you see, it's all healed up. This was like 2 months later. Okay, you saw how scary it looks when you start first look at this image, especially if initial says you'll be saying, can I leave this? Yes, you can, but of course you can monitor the patient. I admitted him overnight, but generally this is benign because the whole septal collaterals are constantly squeezed by your muscle, and it completely healed up in 2 months' time. Epicardial. So this is one of my epicardial perforation. Luckily, nothing wrong went here in the long term for patients. So this was a very epicardial. I tried antegradally. I couldn't go. I went retrogradely, and you could see there is a dye hanging up in here, which is not a good sign. But in this case, I was lucky that I was able to balloon tamponade and stop it and fix the case. this is another complication which is very, very important you'd be aware of, is that this is the LAD CTO. I was trying to do retrograde. Okay, I got my uh, my microcatheter here. I got my retrograde wire into the septal. I was about to do a reverse cart. Okay, and you see I'm setting up a reverse cart. I got my microcatheter, and suddenly patient complained of chest pain, and there was an ST elevation in the inferior leads. You could see there's a dissection in the donor guide. Now, when this happens, it's a nightmare situation because patient has lost the most important artery, which is feeding the collaterals to the left, and patient became hypotensive. Luckily, I was able to bail myself out and put a stent in. So this is another complication you have to be aware of, especially when we take more aggressive guide. Always keep an eye on your guide. One thing about the CTO-PCI is that you have to have your eye on your pressures, patient, saturations, your guide, your wire. It comes with time, with the experience you will get it, but you have to be super alert when you're doing a retrograde CTO-PCI, which is why I never put a retrograde CTO-PCI at 2 o'clock in the afternoon, because one, I'm fatigued because I've been doing case from 8 o'clock in the morning, and the nurses are fatigued, the cath lab is fatigued. The last thing I want to put a complex case at 2 o'clock, 3 o'clock. We are under time pressure. We have to finish the lab by 5:36, and fatigue sets in, mistakes happen. If complication happens, it's difficult to justify, especially for patients. So I never put a retrograde complex CTOs in the afternoon. I tend to do them all in the morning, and even I'm happy to cancel the case and do next day. I don't want to be doing with the pressure on. I'll like show you one example. This is a very nice case we did in a center. 66-year-old man with angina. He had a bypass in 2015 where he had lemur to LAD and vein graft to marginal. But for some reason, the surgeons didn't graft the right coronary artery, and we were not sure of the reason. He was having ongoing angina despite maximal medical therapy. So we did the angiogram in October 2019. What we found was that the left system was okay, and the lemur was patent as always. And this is the vein graft to the circumflex. So vein graft to the circ was okay. Lemur to LAD was fine. Um, the RCA, we could not see the ostium. Okay, so the origin was not clear. So we didn't know where the origin was. We looked at the pre-bypass angiogram. Okay, so this was the pre-bypass angiogram. The operator again did not intubate the RCA properly. Even then, they had struggling. So even the RCA angiogram before the bypass, this was in 2014, was not helpful. So what do? We did a CT. I'll play the CT very carefully. So okay, maybe I'll use this one. So this is a contrast CT. Okay, so that's your left system, and just watch the right side here. Okay, you'll see a vein. So there is some contrast in. Now we don't know whether this is the RCA or that conus branch. Sometimes the conus branch comes separately from the RCA, directly from the aorta. So we are not sure what it was. Anyway, so I spoke to the cardiothoracic radiologist. He said it may be the RCA, but he was unsure. This is another view. Okay, probably there. Anyway, so our strategy was upfront retrograde because we had no antigrade vein here. So we got the nice septal collaterals. We took a microcatheter. So this is just a Sion wire. You see here, it's a septal surfing, goes nicely into the distal RCA. There. At this point, okay, I spin the microcatheter. As you could see here, is it not? Yeah, so I anchored the balloon in the circumflex and I'm spinning the microcatheter. Okay, this is technique, as I said, I do it a lot, especially when the collaterals are very tortuous. You put an anchor balloon in the circumflex, small branch, ask the second operator to give a gentle tug on the balloon, and then you just spin. And you see here, my microcatheter went and my wire is already here. Okay, and I got the anchor balloon still here. I got my microcatheter. At this point, I came into the retrograde. I decided to go retrograde wire escalation. Okay, so here you see here my microcatheter comes in. Okay, I'm nicely set up for a retrograde wire escalation. Okay, Now, as I said, if you don't have any antegrade here, it's very difficult to do a reverse card. So this is where you should try and do something called a retrograde wire escalation. And here, what I did was, so I took a Gayatri wire and penetrated the cap, and the wire went, and wire went here. Do you know where the distal tip of this wire is? This is just a normal wire after that. Can anyone guess where this wire is?
Is it in a graft?
Yeah, nice, Azim. Well done. So what I did was I injected in the aortic root, and a lot of the time you have to be careful because you could be in the wall of the aorta. So, but here this gone into the graft. So that made me very confident that I'll be able to externalize this. So at this point, I did a nice technique. So what I did was I put the wire in that branch, what I was seeing, which could be conus, whatever. I took a balloon, just a 2 mm balloon, inflated the balloon, and tucked the entire guiding system in here. And then once that was in, I just took a retrograde wire back in here. You could see here, I'm trying it's like a trial and error, and finally it goes in. Once that's done, it's fairly straightforward. After that, you balloon.
So why not, if I can ask, why not snare the wire in the ascending? Because I mean, the risk is always you pull back and maybe you only got into true lumen right at the ostium, right? And you don't want to give that up.
Yes, that's a very good point. I tend to use snare if this didn't work.
Okay.
Because my slide was snaring, I know snaring people say, but you got this end snare which keeps coming out and out in the aorta with athyroma and all those things. There's
Right.
always the risk of stroke and
Stroke
embolization.
and so on. Sure.
I try this technique a lot. I bring the GR4 guide very close to the ostium and I try and fish and go in.
Okay.
Because I would have spun the microcatheter, so I would have made a room, you can get back in. You're right. If nothing works, snare is the last option. For snaring, you always have to put the RG3 for snaring. And we finished this procedure and patient's done well. So this was done in 2021 and we haven't seen him since then. So in summary, retrograde PCI will be needed in proportion of cases, no doubt. As you embark complex CTO, as you saw in the graph earlier, as it goes to JCTO 4 and 5, almost 30 to 40% of cases has to be retrograde. So don't shy away from it. But you have to train yourself in retrograde CTO-PCI. It's a long learning curve, but the way I look at interventional cardiology is it's a marathon. So it's not a sprinting. So you got enough time to learn. And setup is very important. And these days, we have so many courses. I was at the Euro CTO meeting last week, and they did 12 live cases. So I'm sure the New York course is one of the biggest one. The one run by CRF. I mean, that is one where you do a lot of cases. You see a lot of cases. So yeah, know your steps. Again, more you do. So even as a second operator, third operator, you learn a lot. So when I started doing cases, I was a third operator when Dr. Nakamura was coming to Milan when Azim was working. Sometimes I used to be the fourth operator. It doesn't matter. You just stand there, you learn. And be gentle on collaterals, especially epicardial. I would say don't embark epicardial, especially in the early stage of your retrograde CTO-PCI. Try and do more septals. And then when you're happy with the steps and the whole procedure, then you go on to the more complex one. And you should be aware of the complications and knows how to treat them, because complication will happen. If someone says, in fact, Azim said to me very nicely when I was training, if someone said they had no complication, either they're lying or they've not done enough cases. So complication will happen and you should know how to treat them. And one last thing I would say is any case you do retrograde, I mean, I do most cases, I record them. So I just take the patient details and I collect this because they're extremely nice for presentation and teaching material. Thank you so much.
Thanks, Sandeep. That was awesome. That was great. And I really appreciate you sharing your experience. Also great seeing, I mean, how experienced you've become and how much you've learned. So before we have a whole lot of faculty but before I pass it to them, maybe there's young people on, there's fellows on, and they see these crazy, amazing cases. I think CTO-PCI has really revitalized coronary interventions, because everything was so focused on structural and valves, and CTO-PCI has a really invigorated coronary. So for a young interventionist, not even a fellow, even a young attending who wants to learn CTOs or get more involved in CTOs, can you maybe give some advice on how you got to where you are?
So, obviously, my CTO career started when I was with you guys in Milan, where Dr. Colombo was doing, you were doing it, and then Nakamura was supporting the cases. Carlino was there. So, I think first thing to do is you have to decide if you want to be a dedicated CTO operator, you have to put in time and effort. There is no second option to it. I would say these days you're extremely lucky because there's so many online materials, YouTube, in Cath Lab, and all these, access to the TCTMD, where there are lots of recorded cases and some excellent courses. The New York course is great. We have the Euro CTO meeting, which happens every year. I think you should try and come to that because they're a slightly different way of doing CTO PCI, Japanese approach. So the way I look at it is see all of them, learn all of them because you need all three of them, like a conventional, hybrid, and in between, what we call best of both worlds. um, and yeah, and then you have to start to see the only way you can do is you have to bite the bullet or try the cases. Start with antigrade. If you want to go retrograde, start with the septals. Improve your techniques. Put in time, and after every case, review yourself. Even failed cases, you have to show the case to someone. Let's say if you fail, see what to do next, and then you slowly look. It happens. The way I look at it, this is not a rocket science. All you need to put time and effort, it'll happen.
Sure.
And the whole interventional cardio is a self-selecting field. If you're not good enough, you'll never reach to where you are now. So the fact that you all reached here, which means that you can still go ahead far, and you just have to keep trying and writing. So the way I did my cases were, we brought Dr. Nakamura into our unit every year. I saw him do. I was a second operator with him constantly. He was teaching us. Then I used to went to many courses. Then at the end of the day, you have to try. I mean, being courses, seeing cases, great, but you have to try it out.
Right. That's great. Thank you. Maybe one other question I have for you, and again, it's just because we have a lot of young cardiologists who are on the line, many of whom won't go in intervention, but they'll be our referring cardiologists. What you showed, you also talked a lot about complications and complexity of doing CTOs, integrate, retrograde, all these different techniques. But there's still a lot of discussion about unstable angina, just even without a CTO, about the benefit of PCI, right? And yeah, these procedures are higher risk. So, I mean, how do you balance risk versus benefit in the sense of what are your indications currently for opening a CTO? And what do you, advise, these young doctors who are listening, who are going to be referring patients to us, what are the kind of patients they should say, this CTO we should just leave alone. This one we should send to the interventional team to open.
So that's a very good question, actually. The one of the holy grail of intervention are we making patients live longer. With stable angina, we don't have the data. Okay. Now, I don't apply this blanket rule because if I have a 50-year-old man who bicycles, who goes for a hill walking, and he has a LAD CTO, and if someone tells me, can you not manage this medically? I would say, hang on, man, this chap is so active. And, you could tell the patient they are symptomatic when they do all these exercise. I would go more active and open the artery. Whereas if I see an 80-year-old man with an LAD CTO, I'll ask him how much activity he does at home. He said, look, I'm able to do all my physical activities with no angina, shopping, cleaning, whatever, gardening. If he's enjoying all his activities without angina, I wouldn't even go anywhere near him. I'll tell the patient, you have a blocked artery, but it's not causing any problem, just carry on. So I still optimize anti-anginals. But in a younger patient, I'm more aggressive in opening the artery. Our setup is such that if I get a referral, I see the patients face to face, or I have a dedicated CTO nurse. She sees the patient face to face. She ensures patients are on decent anti-anginal, and we ask about the patient's questions. My simple question is: are you able to do all your activities which you were doing a year or 2 years ago? If the answer is no, that itself for me is enough to say this patient needs angioplasty. Now, a lot of the time, patients slow down because they'll put it to age. Oh, I used to do hill walking before. I can't do anymore because I'm old. But if you genuinely ask them, they have angina. The second thing you have to demonstrate is ischemia before embarking. Viability, not anymore because the data is very weak and weak for viability, unless there's a thinned and dead myocardium, which is obvious on an echo or an MRI, I won't touch it. But if it is some scar, if the artery, the muscle is still thickening, I offer a PCI. So yes, you have to go through a dedicated CTO program where you have a clinic set up, you have a nurse, we have a referral base. We don't rush into any procedures. We ensure the patients on an anti-angiogenic treatment and then offer a CTO. So we have to justify what we're doing. So, one blanket rule doesn't apply, but that doesn't mean that we have to open all the CTO-PCIs.
Cool. Thank you. Andrea?
Hi, Sandeep. I really enjoyed listening to you again and seeing these interesting cases. I have a question for you regarding the tipping technique. So after you gain retrograde access, do you always try to do it and work antegrade or not? And why?
So the tip-in technique I tend to use more for epicardial collaterals, and also in clinical collaterals where there is more ischemia when we are accessing it. So patients are getting some chest pain or some ST elevation. So I want to stay as less as possible in the retrograde system. So as soon as I come into the antegrade guide, I go for tip-in. The only disadvantage of tip-in is that if you got a heavily calcified arteries, the retrograde system gives you an amazing support. You can work on the retrograde system. That's the only time I probably work on the retrograde. But if not, I tend to do the tip-in and I work on antegrade. Now, the other thing you have to understand, if you have a septal collateral into the LAD through the RCA, you never enter in the distal part of the LAD. You will enter somewhere from the mid segment. So even if you externalize, you will have to put a dual lumen catheter to go into the distal LAD. You understand what I'm saying? Because you've come halfway through the LAD, got into the occlusion, come into the guide, externalize the wire, but you can't just work on it because you have to secure rest of the LAD. So you put a dual lumen catheter. So if I get a dual lumen catheter, I secure the LAD, then I take the retrograde system out and work on the LAD. These days we have guideliners, enough guiding support. I use, Xeon extra support, all these wires. Generally, we are okay with support.
Right. Antonella, Andrea, Pierre, Saul. There we go.
Hi, good morning. I have a question actually.
Yeah.
How predictable are these procedures? I mean, I think before getting in the cut, you try to plan everything in detail before going inside. But at the end, when you are inside, are more the surprises, or actually you stick with the plan and yeah.
That's a very good point. So there are two aspects to your question. One, I am preparing for my case almost 1 week before. So literally, I know next week which case is coming on. So I've got this mental thought all the time. This is my routine, okay? It may or may not. And a night before my CTO, I normally go for a run or a swim, where I'm constantly thinking, I want to be by myself. I sit, I'm reflecting on the case. How do I do access and everything? I always think. But when I come on that day, there are times I have changed my decision because something didn't work. So you have to be dynamic in your decision making, that you have to switch plans. So even when I'm thinking a night before, I'll say, okay, I'll try this. If it does well, maybe I'll try that. So you have to have this plan in your mind. I never come to a CTO case looking at the case just before the procedure. Never. I always know what I'm going to be doing, because it's very important you come mentally prepared, physically prepared. But during the procedure, there are times where I've changed my plans a lot because it's not working. Of course, failed cases. My success is not 90%. It's probably 80, 85%. But having said that, I take a lot of complex cases. So cases do fail, but if they do fail, then you call this as an investment procedure. So you know what worked, what didn't work this time. Maybe next time you come back and you try different techniques. Sometimes I've tried third attempt, I've been successful. But first attempt is always the best attempt. So you give your maximum time, ensure that you're not fatigued. So if I'm on call, I had a very bad night, probably I cancel my CTO. Sometimes I'll just postpone them. So yeah, it needs careful planning with CTOs. Yeah. But that's a very good question, because I went through this thing. Some people say, no, don't look at the CTO, look at it on the day, because otherwise you'll stress yourself for the I'd rather stress myself and be more, thinking, rather than coming on the day and finding out the surprise and difficulties of everything.
Thanks.
Right.
You
Yeah.
agree with that, Azim? That makes sense, isn't it?
Yeah, absolutely. I think preparation is very important for cases. I think, the days of just walking in and doing ad hoc complex PCIs kind of should be avoided. I think, whenever it's a very complex case, do the diagnostic, stop. Even if it's not a CTO, even if it's just, complex left main, a complex patient, low EF, whatever, do the diagnostic, stop, plan when you're gonna, the procedure, are you gonna need, anesthesia support, MCS, whatever. I think it applies to CTOs, it applies for all across complex PCI.
No, I think that's a very good point. I mean, a lot of the time, as I said, I've taken times which just stopped. Okay, look, let's do it another day a bit more.
Yeah, I agree. Pierre?
Yep. Sandeep, thank you so much. Very, very, very nice presentation. And I have a real quick question. And I am really, really appreciative of your talk on CTO, and I'm at least as much appreciative about all your efforts on DCB technologies and DCB angioplasty, especially in de novo lesions. And I feel like possibly CTO is kind of a scenario where DCB angioplasty can really be helpful to operators, and especially in Europe. And I'm just wondering, what's your share as of today of PCIs and CTOs where you end up doing stent only, those ones where you do some hybrid stent plus DCB, and those ones where you do DCB only? And if you think during investment procedure or anything like that, DCB has any kind of role. And I'm just curious because you're really the great person to ask, being in the middle of CTO and DCB panorama.
Yeah. No, I think that's a very good point. The data on CTO and DCB is very, very sketchy in the literature, as you know. So my approach is that if I'm true to true, when I do the IVUS, if the vessels are 3 or 3.5, and if I make a nice lesion preparation, and if I get a good flow with no recoil, I do the same like I do for the de novo non-CTO lesions. I put DCB. There are some cases where I do hybrid, as you said. I stent the proximal LAD and mid LAD and put a DCB for the rest of it because it grows very nicely over time. I've seen so many cases like that. If you have a heavily calcified CTO, that is where DCB, I'm not so sure, because you get a lot of recoil, even with the shockwave and balloon. So I don't accept it, because the last thing I want to do is, having spent 3 hours opening a CTO case, to accept a DCB result with a suboptimal looking angiogram. I don't do it. I put a stent in, because most of the time when you put stents in these arteries, you put 4 or 5 millimeter stent. And when you put such a large stent, the ISR is very, very, small. The last point is the subintimal space. I've spoken to Bruno Scheller. Obviously, he's one of the most experienced in this field. He's slightly nervous putting paclitaxel in a subintimal space because, as you know, paclitaxel heals by adverse remodeling, and the last thing you want to do is create aneurysms in subintimal space. Now, there is a study going on in Amsterdam by Paul Nappen. They're, I think, almost finished the recruitment where they do DCB, and he says he's happy putting in subintimal space. Let's see the results. But till then, I'm a bit skeptical putting in a subintimal space, but I do use DCB in CTOs in selected population and subset of lesions.
Thank you so much.
Agree. That makes a lot of sense. I also worry about the subintimal space, but then I kind of worry about, isn't maybe leaving nothing behind better than putting a stent on the subintimal space? I don't know. Maybe with sirolimus coated balloons that don't have that toxicity of the vessel wall, we'll find a role, especially, when you guys do these, especially these hybrid procedures with long areas of subintimal tracking. I just wonder whether they're, longer term drug-coated balloon rather than a stent will result in better outcomes.
Yeah, I mean, I think that's a good point, because subintimal space stenting, again, we don't know the long-term outcome for these patients. Maybe but you're right. Certainly, we should explore the sirolimus one.
Sahul, do you have a question?
Good morning. Yeah, thank you for your presentation. As a new attending that I'm approaching perhaps simple CTOs where I wanna opt for an integrate approach, is it always worth to start up front with 2 guides? Is it worth the risk of having an extra guide and an extra axis?
So You made a very good point. If you have a CTO, you should never work on one guide. You should always have a dual access, because even if the CTO is very simple, you'll be caught many times that you go subintimal. The problem is if you only have one guide, you don't know unless you have to inject through a guiding microcatheter. And if you're in a subintimal space, the case is almost over. So always put a second access. Look, the way I do it is, this is my practice. Maybe it's something you can take. I always put a 7 French sheath in the radial, and I put a 5 French access in the femoral, or sometimes in a 4 French, because with that you're making a smaller hole. And if you're likely to circulate antegrade, you can always upgrade to a 7 French if you want to go retrograde. So I always put a 5 French guiding catheter into the RCA or LAD, the retrograde donor vessel, and you put a safety wire and inject. Very rarely you will have any problem. The problem is if you don't have a second access and you try to do antegradely, there's a risk of that you will fail, and if it fails, it will fail badly, and it's a failed attempt. So if you're giving a proper attempt for CTO, always have dual access.
Right, great
Excellent.
point.
Makes sense. Thank you.
And then there was a question from Yumiko about the can you comment on your anticoagulation, antiplatelet strategy when you do the retrograde approach going through collaterals, and what do you do about reversal when you have a perforation?
That's a very good point. So let's start with the anticoagulation. So I always keep the ACT of more than 300 when I'm doing a retrograde. Antegrade, I'm not that obsessed, because you're not one of the main concern with the ACT less than 300 in retrograde is the thrombosis of the kits, especially in the retrograde system where the pressure is low in the epicardial or septal collaterals. So 300 plus is for retrograde. But if it's antegrade, I tend to keep anywhere between 2 to 300. And you have to have a clock. So we have a clock in our system that every 30 minutes, the physiologist reminds us the ACT. So the sound will be always on you. So which means you won't miss it to check. If you have a perforation, I want to fix the perforation. The last thing I want to do reversal in ACT. I'll tell you why. There are 2 reasons. One, if there's already a stent, reversing the heparin by giving protamine increases the risk of stent thrombosis. The second, when the blood leaks in the pericardium, it becomes a jelly if you give the protamine. So you want it to be more free flowing, so you can take it out, auto transfusion, whatever.
Yeah.
But you want to ultimately fix the mechanical problem where the perforation is. But if you give the protamine, you will make that pericardium into a jelly. Then there's a risk of constriction and you can't aspirate it out. So I don't give any more protamine at all. The only time I give protamine is that if I have an access problem, I finish the case, I have to take the access out quickly, like femoral, if there's oozing, whatever. Then I give protamine if I've not put a stent in, I failed a case or whatever, I'll use a DCB. And I take the catheter sheath out maybe in the next 10-15 minutes after giving the protamine. But otherwise, I don't give protamine for perforation.
Great. Sandeep, thanks so much. Really appreciate your expertise. We all learned again. Great cases. I look forward to seeing you at TCG.
Yes, TCT. Yeah, I'll be there from Saturday night. Yeah, Sunday. I'll see you Sunday, Monday. Yeah, I think we're doing a session together, so I'm looking forward to that.
Perfect. Me too.
And thanks, Azim. Thank you all. I'm glad you enjoyed.
Take care. Enjoy the rest of your day. Thank you for making time for us.
Thank you.
Thank you.